Good evening, everybody. Thank you all for taking time out of your Friday evening to join us. I think this is going to be a casual but hopefully super informative session on thyroid radiofrequency ablation. I am super thrilled to moderate this session. I'm Dr. Yinan Hu. I'm an assistant professor of surgery at the University of Maryland in Baltimore. I've been offering RFA here now for a little under a year. I've been happily impressed with the results. I do engage in research on patient preferences and treatment value, so this webinar is very sort of near and dear to my own interests. I am very privileged to be joined by a panel of RFA experts today. I will admit that I am awful when it comes to introductions, so I'm going to go ahead and let the panelists introduce themselves, and let's go ahead and start with our fantastic patient advocate, Ms. Jennifer Holcomb.
Well, thank you. I appreciate the fantastic part. Hi, everyone. My name is Jennifer Holcomb. I am the founder of the Savior Thyroid online community, and that community was something that I felt the need to start after I had a very difficult time finding RFA on my own, and was fortunate enough to encounter another patient who had undergone this procedure, and she just talked me through all the ins and outs of it and just really put my mind at ease. And I decided surely I wasn't the only person that needed to know this information. And so Savior Thyroid was started in middle of 2019, right after my procedure, and has grown to around 5,500 patients. So we're really excited that so many people are now learning about RFA and other options that will allow them to save their thyroid.
Wonderful. And so down here at the panelists, let's start with the upper left, Dr. Kuo.
Hi, everyone. I'm Jen Kuo. I'm an endocrine surgeon here at Columbia University in New York City. We started our interventional endocrinology program offering RFA and ethanol ablation in 2019. I'm happy to be here tonight.
Great. Dr. Taylor.
Hi, I'm Josh Taylor. I'm a general surgeon and focused on endocrine surgery. I'm located just outside of Nashville, Tennessee. I've been performing thyroid RFA for the last year, and I see folks primarily for benign nodules that I treat.
Excellent. Dr. Reeves.
Hi there, I'm Alan Reeves. I'm the Director of Interventional Neuroradiology at the University of Kansas Medical Center in Kansas City. We've been doing interventional thyroid stuff for several years, but for RFA, we've probably been doing it for about a year and a half now, and it's been a great addition to our repertoire.
Fantastic. And Dr. Wren.
Hi, good evening, everyone. My name is Sean Wren. I'm an endocrine or thyroid surgeon at Rush University Medical Center in Chicago, Illinois. I've been performing RFA for the thyroid a little over a year now, and predominantly perform this procedure in the outpatient clinic setting, although occasionally we'll perform it in the operating room when indicated.
Excellent. Okay, thank you all for lending us your expertise tonight. I'll do a very quick overview of sort of the format. We will be diving in to several firsthand experiences of RFA told by the patients themselves. I really hope that these cases will cover some of the more common scenarios that some of us in the audience will have experienced as well. After each experience, I'll go ahead and pose a few questions to our expert panel and hopefully stimulate some thoughtful discussion. Sometime around the 45-minute mark, we'll shift over to an open Q&A format. We've got 4 cases. We'll see if we can get through all 4 cases before that point, but I want to leave plenty of time at the end for folks to have a chance to ask burning questions. During that time, those last 10-15 minutes, use the Q&A function. It's going to be at the bottom of your Zoom screen. It'll look like 2 little speech bubbles. and open that up and type in your questions. And we will have folks on the panel who are going to look through those and choose out the ones that hopefully have relatively broad applications. Those of you who do not get your question answered, don't fear. We're going to have all of the panelists' contact information up on the screen at the end, and you should feel absolutely free to contact any of us and ask your question afterwards. As you type these questions in, we do ask you to be discreet about specific names, both your name and any physician names. Our goal today is to try to stay as compliant with sort of medical confidentiality as we can. But with that, let's go ahead and dive in with the first case. Jen Holcomb, you mind introducing our first presenter?
Yes, and I just want to take a quick second to thank all of the patients that are going to share their stories tonight, and just hope that this will be helpful to all of you who are watching. The first patient is Stephanie. She is from Indiana, and she had a benign thyroid nodule. Stephanie, will you tell us your story?
Thank you so much, Jennifer. Hello, everyone. As Jennifer mentioned, I had a benign nodule. I first noticed the nodule in my thyroid area in 2008. It was around Thanksgiving. And I just felt my throat, and it felt abnormal. So I did make an appointment and saw an endocrinologist to assess it. And he did identify it as a goiter. At that point, it was quite substantial for him. Monitored that goiter through ultrasounds and fine needle aspirations, which we will sometimes hear as FNAs, or just a biopsy is what that's assessing, to make sure that even though the nodule was growing, it was not cancerous. And I would do that procedure year over year, and the nodule continued to grow. It was recommended by my endocrinologist to have it out, to have the surgery, even though my levels were pretty much stable year over year. I never had to take medication. My TSH, my T4, my T3, all of those numbers, according to the ranges, were normal. So I did not want to have the surgery. In the most recent years, my goiter did start to interfere with my trachea. I would have issues sort of bending my head down, not so much swallowing, but it was different for me. And that's when I started to explore RFA. I found Jennifer's group. I studied the group for at least 2 years, and a lot of the recommendations of different, surgeons and doctors, and ultimately landed on a procedure. I did travel for the procedure. I had an outpatient procedure. It was successful. In 3 months from my RFA, I had an 85% shrinkage, which is pretty phenomenal for what I hear about RFA. I can no longer see the goiter. It was quite large, and I honestly can't even really feel it unless I'm really being intentional about feeling it now. And so I do consider RFA a success for me in allowing me to keep my thyroid. And I hope that helps you today.
What an excellent story. Thank you, Stephanie. All right, well, I think it's clear to the physicians on the panel, but maybe not all the folks in attendance, but RFA is not quite the same experience as a typical outpatient surgery. Dr. Taylor, can you tell us a little bit about sort of the typical patient experience on the day of ablation, walking into your facility to, let's say, a couple of days after treatment? What's that like?
Yeah, so I perform all of my RFA procedures in our radiology suite at the hospital that I operate at. And so a patient would come in for the procedure. They have the option of being able to receive some IV medications for anxiety to help them be more calm. It'd be very similar to a patient who would maybe have undergone a colonoscopy. So if you ever had any type of scope type procedure, or sometimes even like dental type work, you may have received some sedation. And so I offer that as an option to my patients. I would say that probably about 80% of my patients do ask or desire for some level of sedation for the procedure. So they would come in, they would register, they'd then be taken into the area where patients who are undergoing any other procedures or evaluated. A nurse would place an IV, and then we would then have the patient taken over to the radiology suite where the ultrasound is available and where we would perform the procedure. The procedure itself is usually about 30 to 45 minutes in length. Like I said, you would receive sedation, but I want to make sure that you are awake enough that I can talk with you. I can monitor any symptoms that you might be having. Are you experiencing any pain or discomfort? In preparation for performing the procedure, we will use a numbing medicine that I inject utilizing an ultrasound to make sure that when I'm inserting the RFA needle that you shouldn't feel that and minimize any level of discomfort. In addition, you being awake enough to interact with me can help me monitor for any sort of unwanted side effects from performing the procedure. After performing the procedure, the patient is then transported back to the same day area, they call it. And usually within about 30 to 45 minutes, if they receive sedation, they're typically able to go home. If you do receive sedation, then we would want to make sure that you have somebody that can drive you home for that. If you don't receive sedation, then most folks will be able to drive themselves home.
And are your folks going home with Tylenol, ibuprofen, opioids? What's the medication regimen like?
Yeah, so I routinely tell folks to, if they have any discomfort, I recommend utilizing Tylenol or ibuprofen. I also recommend using ice to help with any level of swelling or discomfort at the insertion site where we perform the procedure, as well as where the nodule itself was treated. I have not sent a single patient that I have treated up to this point with anything stronger than Tylenol or ibuprofen, and I would tell you that the large majority of the patients that I've treated have not even had to take anything for any discomfort.
That's certainly a little bit different than having a thyroid surgery. So you mentioned that a lot of your patients are on a little bit of sedation, but they do talk to you. They're awake enough to sort of follow directions. They might overhear some things kind of being said in the procedure room. Now, we surgeons love to chat while we do our procedures, and a lot of the jargon is not very intimidating to us, perhaps, but could be intimidating to patients. So since these patients may be awake and may remember some of those terms, what are some numbers, phrases, vocabulary that they may overhear that could potentially be a little bit nerve-wracking? Can you kind of illuminate some of that for us?
Yeah, absolutely. So, from getting back to starting the procedure, the nurse may ask me, how much medicine that I would want to give. And so the typical medications that a patient would receive would be a little bit of pain medication, something like either morphine or fentanyl. Those are the common IV medications that can help with any pain or discomfort if they're experiencing that. And so you may hear us talk about dosages for that, as well as the sedating medication. Most commonly, we use something called Versed. And then when we're evaluating the nodule, I'm going to perform an ultrasound prior to treating it, and we're going to obtain some measurements. And typically, we're obtaining measurements to be able to monitor the treatment effect after. And so, hear some of that, and I'm sure that would be familiar for a patient in terms of centimeters. And we even talk about the volume in terms of milliliters, typically of the size of the nodule that we're treating. And then as we get ready to treat, I'm gonna talk to the nurse or my assistant and say, I want the watts, the wattage set on the device. Typically for a smaller nodule, I would start at 20 watts. So watts are just the amount of energy, energy that is being given through that little needle device to perform the ablation. So as it's being activated via radio frequency waves, it's delivering energy into that nodule to cause it to essentially be burned internally so that it will over time shrink. And so you can hear something about the wattage. And then as we're treating the nodule, so as I begin the treatment, the other thing that is called out to me as I'm treating, because I'm watching carefully on the ultrasound, my assistant is going to be calling out numbers that are called an impedance. And so that's how well the tissue is conducting any sort of electricity. And as that impedance builds, so the numbers go up, you'll know that you're effectively, or I know that I'm effectively treating that area. And when it reaches, usually within the 100 range, I begin to know that the treatment is becoming effective. And then very quickly, those numbers can jump up because that as that tissue gets burned, that impedance really rises rapidly. One of the concerns that sometimes people have, or I've heard, is that the temperature? Is that like how hot it is internally? And that's not the case at all. It's purely just telling me, have I effectively treated the tissue? Is it conducting sort of electricity through the tissues anymore or not?
Fabulous. All right. So Stephanie clearly had a really good response fairly quickly for her nodule. Dr. Ren, when you look at patients in your office who come and ask about RFA, what's like the ideal nodule when you're thinking about candidates for ablation? And what do you tell patients about what to expect in terms of treatment response?
Yeah, so my short answer is that a patient like Stephanie is the ideal patient. But to elaborate that a little bit, in my opinion, the ideal candidate for RFA would be a benign non-functional nodule, or a nodule that is been previously biopsied as not cancerous and doesn't have suspicious features when we look at it with the ultrasound. It would be a large single nodule on one side, or a cluster of nodules on one side, and be mostly solid. The ideal RFA candidate is usually driven in some way to avoid surgery, whether it be to avoid the risks of general anesthesia, avoid a scar, or avoid needing to take thyroid hormone supplementation. They should be able to tolerate a procedure being performed on them while awake, and be willing to follow up in the future and okay with the idea of continuing to live with the nodule going forward. And by that, I mean, be willing to undergo repeat ultrasounds, potentially even repeat procedures if necessary down the road.
Excellent. Now, Dr. Reeves, you're an interventional radiologist. Typically, I'm guessing you're performing this in a hospital setting rather than a clinic setting. Can you tell us a little bit about how the experience for the patient differs from a surgeon providing the procedure?
Sure. And Stephanie, by the way, thank you for that story. That's a very good lead-off story. And I think your experience mirrors many, many patients that certainly we've encountered and I think that are out there. So I think this is a great kind of lead-off story with how we approach thyroid nodules, at least in terms of RFA. So the experience at my institution, I think, is very similar probably to what Dr. Taylor described. Almost universally, by the time the patient comes in for the procedure, it will be their second visit to us. So I work in a hospital, a tower and in the interventional radiology area. And so we have a clinic setting immediately adjacent to our pre-post area and our procedure rooms. And my nurses have a checklist of things they go through when evaluating a patient for thyroid RFA. One of those things is they have to have a biopsy within the last year, and it has to be a negative biopsy, meaning no cancer cells were found. So a lot of patients will need to get a biopsy, and what we'll do is we'll perform the biopsy, and Stephanie alluded to this, it's an FNA or fine needle aspiration. We'll perform that biopsy in the interventional radiology area and then do the consult on the same day. So typically we'll do the consult and then we'll do the biopsy. Then we can wait for the biopsy results to come back, confirm that they're negative, and then my nurses will get the patient scheduled. So at that point, the patient will be scheduled for a certain day. They check into the interventional radiology area through the hospital. They're taken back to a pre-post area where all the patients are basically getting prepped for the procedure. For us, we use moderate sedation or conscious sedation. So we start an IV, the nurses start an IV for the patient. We give them a little bit of medicine through the IV to give them sort of anxiolysis, so reduce their anxiety a little bit, make them comfortable. I always go back and see them for the visit, the second visit, and ask them if they have any more questions, kind of reassure them that everything is good to go. So we bring them back to the interventional radiology suite, and the whole thing is done with ultrasound, I think, as most people know at this point. So the procedure itself, anywhere from 20 to 30 minutes, kind of depending on how large the nodule is and how long it takes to ablate the certain areas. So I'll do my part in the room. The nurses are in the room monitoring the patient the whole time. We keep them hooked up to monitors. We do have the patient so that they're awakened enough to know what's going on, but we try to avoid unnecessary conversation with the patient because your voice box sits right by the thyroid gland. And so we don't want the patient discussing anything while we're doing the thyroid ablation because that actually changes what you're seeing. But we take periodic breaks during the ablation itself. The nurses will ask the patient if they're doing okay, if they're feeling any pain, they can kind of titrate the medicine as we need to. The goal is not to knock the patient out, simply to make them comfortable for this procedure. So after the procedure is done, they're taken back to the pre-post area. They're allowed to recover. Our nurses back in the pre-post area always put an ice pack on the thyroid gland. And by the time the patient's done recovering, and it doesn't take too long, an hour, maybe two at most for them to recover, my clinical nurse coordinators will then do a last check with the patient, make sure that they understand what their follow-up is. And we do a 3-month, 6-month, and 12-month follow-up ultrasound. They're given, once again, the number to call in case they have any problems or issues. My nurses always give a phone call at about 7 to 10 days or so to kind of check in, make sure there are no problems or issues. Occasionally, we do have to have the patient take some over-the-counter pain medicines. I don't think we've had a patient yet that's required anything stronger than over-the-counter. And on rare occasions, we have given a patient or two a Medrol dose pack, which is a steroid that can kind of help reduce swelling. Occasionally, patients can feel some discomfort afterwards. You can feel like you might be taking 2 steps back in order to get 3 steps forward because the procedure itself can kind of stir things up just a little bit. And occasionally, we have a patient that feels a little uncomfortable with that. But by and large, for the most part, by the time the follow-up phone call occurs at 7 to 10 days, 98% of our patients are doing great.
I just realized I've been so riveted by the conversation that I forgot to advance my slides. Let me get there here. All right. So one other question I wanted to make sure I asked Dr. Reeves. What if the nodule is partially cystic? Does that change what you do during the procedure? Can those cysts be treated at the same time as the solid component of the nodule?
Yeah, so that's a good question. Historically, and by that I mean over the last 10 to 15 years, these have been successfully treated using ethanol ablation. And ethanol is the exact same thing that's in alcohol. It's pure alcohol. And it turns out the body really doesn't like it unless it's in your wine glass. And so ethanol works very well for stirring up the hornet's nest, as I like to say, and it creates a lot of inflammation and irritation. So the goal for a cystic lesion then would be to drain the cyst and then replace at least some of that fluid with ethanol. And so the body creates inflammation, ultimately leading to scar tissue, and the scar tissue kind of acts like glue and can kind of glue the walls of the cyst shut. Almost always, a cystic nodule has some solid component to it. So when RFA came along, the question is can this be effectively treated with just RFNA, or do you need to use a combination of things? So at my practice, what we've opted to do is use just RFA. So what we do is we drain the cyst and then target the solid components with the RFA probe. So far, that's worked pretty well for us. We do that intentionally so that we're not mixing complication profiles. The complication profile for ethanol can be a little bit more detailed, I'll say, than the complication profile for RFA. And so we've enjoyed the RFA treatment protocol because the complications are a little bit more predictable, and they're very unlikely to happen, to be quite honest with you. Ethanol is a little bit different story. If ethanol touches a nerve or even a vascular structure, it can cause damage to those things. And so it's hard to control ethanol. It's very runny, and once it's in, it's in. That's all you can do is hope that it stays where it's supposed to stay. The RFA probe is a very deliberate and prescribed ablation method. And so by draining the cyst and getting rid of the fluid and then ablating the solid component of the lesion, for the most part, this has been very successful in reducing the overall size of the nodule, including the cystic component. All cyst will return unless something is done permanently to change the nature of the cyst. So simply draining the fluid by itself won't ever work. It's a very short-term solution. But we found that in combination with draining the cyst and then ablating the solid component, that so far it's been very successful.
Fantastic. All right. We're going to need to speed along a little bit here. We want to try to get through all the cases. Dr. Kuo, I know your practice attracts some patients from out of state. Stephanie went out of state for her procedure. How do you consult on these patients from out of state? Is it a telemed visit, or do you fly them in, and then afterwards, how do you follow them afterwards once they've returned home?
So it's difficult, right? During the pandemic with the Medicare lifting of restrictions, it was really nice because you could do telemedicine all across the country. But we're now back to pre-pandemic limitations. So for patients who are out of state, and I am not licensed in that state because I am now licensed in some additional states where we have some patients. I really want to make sure that it is a worthwhile experience for the patient, that I can really help them before they actually get on a plane and come to New York. So we will generally ask the patient to forward all of their charts and medical records to us. I'll review, and I will actually just call the patient on the phone, and we'll have a discussion and basically have the same discussion that I would have with them if they were in person or a televisit, but it doesn't count as anything. But it does at least, kind of establish some ground rules, really discerns whether or not my capabilities and the expectations of what the interventional ablation procedure could provide does align with what the patient's expectations are. And if everything is okay and, we think we can proceed, then we'll schedule the visit. And again, to minimize travel time, hotel stays, etc., we will do the consult and the procedure on the same day. I generally, since we're lucky enough to be in New York, tell patients to try to make a little vacation out of it, come for the procedure, do it on a Friday, have the weekend to enjoy the city. Just because of the immediate post-procedure swelling that we see in the first 48 hours, I think it would make them a little bit more comfortable to be nearby. Certainly would make me more comfortable to have them nearby. And we really don't know what the pressure changes in the airplane cabin can do to ablated nodules. I've had a few patients just get right back on a plane and travel back home, and they've been fine. But at least from a surgical perspective, we know that pressure changes can actually open sealed vessels. So I've always been a little bit wary of people traveling immediately after the procedure.
Another question that folks have often is that the coverage from insurance companies for RFA is potentially spotty, to say the least, depending on geography. I want to open this up to all the panelists. What are your processes for getting third-party coverage? Do you do that ahead of time? Do you do it afterwards? What's your success rate? Do you find that it varies by geography? Let's start with Dr. Reeves.
Yeah, I know this is an important question, and I would feel it would be very important if I was a patient too. You want to make sure that this is going to be covered. We haven't had any problems in my geographical areas. So my clinical nurse coordinators, as part of their checklist, always get pre-authorization prior to anything really. But when this first came online for us about a year and a half ago, it was a new type of pre-authorization. And there were a few little hiccups with the insurance companies understanding what was going on. RFA has been a technology that is actually an old technology. It's been used all over the body. We use it in other parts of the body too, including the spine and liver and other places. So fortunately, I think at least the insurance companies in my geographic region were familiar with the term. They just weren't familiar with the body part that was being targeted in this particular case. So early on, there was a little bit of back and forth, I think, that my nurses experienced. But since that time, we haven't had any problems with pre-authorization. And it's a question that's on the patient's mind. But for us personally, it hasn't been an issue for the last probably year or so.
Dr. Ren, how about you? How's this going in Rush?
So pretty similar. We usually submit for a prior determination or a prior authorization through the patient's insurance prior to booking the procedure. In my experience, it is usually approved, especially now as the procedure has become more mainstream. We do have instances where a patient might elect to pay out of pocket if their insurance is not willing to cover the procedure. Although we will fight with the insurance companies in an appeal process from time to time to get them to approve, and much more often is it successful than unsuccessful.
Dr. Taylor, how about you?
Yeah, I mean, I would echo what has been said. I mean, we certainly try to work with insurance companies. That's our first line. We're seeing more and more. I've been going through appeal processes with insurance companies, and as I've been treating patients, actually using my own data for the effectiveness of it has actually been very helpful in that appeals process with insurance companies. And so I would say probably 75% of patients at this point that I'm seeing are being approved. I do have an option for folks that if their insurance is not covering it, that there is a self-pay price that we can get it arranged as well.
And then finally, Dr. Kuo, how's it looking in New York?
Aren't we lucky in that we're in the Northeast? So the Northeast region is the notoriously poor region when it comes to insurance coverage. It is better now than it was 3 years ago when we first started. Almost all were denied when we first started. We do everything in an outpatient setting. So we do get pre-authorization from all of the insurers. Pre-authorization is basically telling them, we have this patient with this diagnosis and this is the procedure we want to do. And interestingly, in the outpatient setting, it almost always gets approved. But pre-authorization does not guarantee reimbursement. And that's a difficult concept to understand. If you really want to push your insurer before the procedure is done for them to state whether or not they will cover the procedure, it's a predetermination process, which is different. And even then, they can always change their mind. And they won't always agree to do that predetermination process. But we'll get pre-authorization. We go through with the procedure. We will charge the insurance company. We will do an appeal process. And after all of those rounds, if it's not reimbursed, then the patients are responsible for whatever the set cash pay is.
All right, we've covered a lot of ground with just that first case. All right, let's move on to the second one. Jen, you want to introduce our next patient presenter?
Sure. This next patient is Debbie. I actually had the privilege to meet her earlier this year. She is in Illinois and she had a benign toxic nodule. Debbie, will you share your story?
Debbie, I think you were muted. You might need to unmute your little microphone icon.
Okay. How's that? Hello and good evening, everyone. Sorry, this is my first Zoom meeting. When I was asked to share my RFA experience, I didn't hesitate for a moment because to me, it's been nothing short of a miracle. I came very close to losing my thyroid and needing to take medication for life. I have 2 toxic nodules that caused hyperthyroidism. Discovering them took about 6 years. My TSH first started to go from normal to low or suppressed back in 2015. It wasn't until I was in a car accident in February of 2019 in Tennessee that a CAT scan revealed I had nodules on my thyroid. Eventually, I saw a provider who tested my thyroid levels and recommended I take methimazole to treat my hyperthyroidism. Fortunately, I tested negative for Graves' disease. I decided not to take the medication because I had read it could cause issues with my white blood cell count and liver enzymes. I started seeing a second provider in May of 2019. He did a couple of ultrasounds and found a large nodule on my left side and a smaller one on my right side that he believed were toxic or hot due to the hyperthyroidism symptoms I was currently experiencing. He recommended a complete thyroidectomy, and at that point, I left the office and started looking for alternatives. Once I joined Save Your Thyroid, I found a provider very close by, and after a biopsy on the larger nodule and a radioactive uptake and scan, he declared I was a candidate for RFA, and a date was set for February 26 of 2021. On the day of my RFA procedure, my provider discovered I had Hashimoto's antibodies, and he wanted to know if I still wanted RFA, even though I could go hypothyroid afterwards. I said I had come too far to stop now, and I really needed to stop the hyperthyroidism before it did any more damage. Shortly after RFA, I knew without being tested that I had hypothyroidism. My hands, which had previously always been cold, were suddenly warm. My usual anxious energy was no longer there, and I felt tired and sluggish, and I started gaining weight. At my 6 weeks post-RFA follow-up, my provider started me on levothyroxine to support my thyroid while it was learning to work again. I stayed on it for 6 months and then stopped it for 2 months and had my levels checked. And my levels were normal for the first time in 6 years without any medication. I also had 70–80% reduction of my toxic nodule. I still have a smaller toxic nodule on my right side, but it is not currently causing any hyperthyroidism symptoms or affecting my thyroid levels. I feel really great now. I go to the gym 5–6 days a week, and I sleep great through the night without any medications. Having hyperthyroidism is very frightening. It causes bone loss and AFib, which can lead to a stroke. I had a lifeline screening done in March of 2020 that showed I had the highest probability for osteoporosis, and I was only 57 years old. In January of 2021, I started having heart palpitations just walking around my house. I knew my hyperthyroidism was getting worse, and I let my provider know, and he had me start taking a beta blocker called atenolol. That calmed the palpitations down while I waited for my RFA date. 6 weeks after RFA, I was able to stop taking the beta blocker, and I no longer had heart palpitations. In truth, they stopped right after the RFA procedure. Now that I have had RFA, I would like RFA physicians to know that patients like myself need help navigating the insurance maze. I have great health insurance, Blue Cross Blue Shield Federal. They refuse to pay for RFA based on it being investigational. I felt like my providers were sympathetic to this, but I wish they had offered to help me with an appeal. I was fortunate to be able to cover the cost of RFA without insurance, but there are many people that cannot, and it needs to be covered. My hope is that through sharing my experience, that I can help someone else with toxic nodules to save their thyroid. It was a long journey for me, but I feel so grateful to be here. And I hope my story helps you on your journey to save your thyroid. Thank you.
Thank you very much, Debbie. So it sounds like ultimately had a pretty darn good result again with RFA. Dr. Taylor, when you're considering these toxic nodules, is your selection process different between these toxic nodules versus non-functional benign nodules? Are there size criteria that are different? Is there biopsy criteria that are different? Can you walk us through that, please?
Yeah, so one of the differences certainly is that toxic nodules are almost never malignant. And so I would like to always have at least one biopsy. But in my practice, I typically have patients undergo 2 confirmatory negative biopsies, and I would not necessarily have a patient get a second if they've also had a study that would show that their nodule is actually a toxic nodule. And so very low risk for it being cancerous. And so typically do not need multiple biopsies in my practice. The other aspect of that is that size certainly is important when I counsel a patient on treatment and its efficacy. So if a toxic nodule is larger than about 1 centimeter in size, it would be a little bit more difficult to ensure that we fully treat the nodule and get a complete response, meaning that a patient is able to go back to normal thyroid function with a larger nodule. And so the most important part of that is that they still can be candidates for treatment, even if they do have larger nodules, but they may ultimately end up needing more than one treatment for a toxic nodule. And so the smaller the nodule, the more likely we are to be effective with one treatment in returning a patient to normal thyroid function. And the larger the nodule, the likelihood is higher they may need more lab work drawn, more monitoring, and potentially more treatments.
Right, that's an important point. Thank you. Dr. Kuo, so like Debbie's history, a lot of people are put on methimazole, sort of almost as first line for these toxic nodules. How do you manage this medication after RFA? Are you stopping it immediately, or are patients on it for a little while longer?
Yeah, it's a very good question. And there really is no standard protocol currently. In my practice, I do stop the methimazole the day of, unless the patients are taking a really high dose, and then I'll do a quick titration off of the medication. We do know, conceptually, we are destroying a decent sized nodule, and we are releasing the thyroid hormone that was stored in that nodule immediately into the bloodstream. And so we know that patients are hyperthyroid actually the first week post ablation procedure. Most often they are subclinical, meaning even though their TSH is low, their T4s, T3s are high, they actually don't feel any symptoms. But by 1 month, most people's TSH have normalized. Does methimazole?
Sort of a follow-up question. I've been asked by at least one patient whether being on methimazole ahead of RFA affects the efficacy of RFA. Have you experienced anything like that or read anything about that in the literature?
I think I had a patient ask me the same question. No, I would say it doesn't really affect RFA. I mean, methimazole, the mechanism of action of that medication prevents thyroid hormone from being converted into its active form, right? It doesn't really affect the production of that thyroid hormone. And the RFA is destroying the cells really that are overproducing that thyroid hormone. So there's sort of two different things that are going on there. If you're symptomatic from your hyperthyroidism, you're having the palpitations, you have a lot of anxiety, then you should take methimazole. It is a good first-line treatment for symptomatic hyperthyroidism, but it shouldn't really affect the efficacy of the RFA. It's not going to help. It doesn't actually destroy or have any effect on the actual cells that are overproducing that thyroid hormone.
Great, thank you for that. So I know that we are kind of at the 45-minute mark, but we haven't even mentioned cancer yet. So I want to make sure that we get to the third case first and kind of touch on this subject. So Jen Holcomb, you mind introducing our third presenter, please?
Yes, our third patient is Aya. She's from Oklahoma and she had papillary thyroid cancer. Aya, will you share your story, please?
Yes, thank you so much for giving me this opportunity. And thank you, Jennifer. I just feel so grateful for all that you've done. Just before I start my story, I want to respond just to a couple of things that people said. First of all, I was fully awake for mine, and I think I would have appreciated some sedation. Secondly, I did go to another state for a consult and was turned down. So that was a trip that I made that I think could have been handled via televisit and saved me time and money. Also, the doctor that I did end up using refused to even run or check with my insurance. So that just wasn't even an option. So then to my story, so I had COVID in September of 2020. And upon that recovery, I just had a pain like right in here that would never go away. So speaking with my doctor about that, they cleared my heart and wanted to send me to a pulmonary specialist, which was a 3.5-month wait. So I had purchased years before advanced body scan. And so I got the bright idea to just go get that looked at via that scan that I had also had 3 years before, totally cleared with good health. On this scan, they found a small nodule that they said looked concerning. And by the time I had called my primary care physician, she had already ordered an ultrasound. So this was last year around April. And so after the ultrasound, that was still concerning. So then I went ahead for a fine needle aspiration, which identified my tumor as papillary cancer. The only symptom that I'd ever had up to that point was clearing my throat a lot. And other people had noticed that as well. But other than that, I didn't really seem to have any issues. So I was referred to a surgeon who immediately wanted to schedule me for a total thyroidectomy. And I was quite opposed to that as, first of all, I am a really homeopathic, natural leaning person anyway. So with a second opinion, that surgeon said, great, just removing the left lobe. He was really comfortable with doing that. But I still didn't even want to do that. So I kind of held off on that. And my daughter and I started doing a lot of research. I went on an even stricter diet. I had pretty careful with my diet, being that I have crippling arthritis, and found that controlling my diet would help with those symptoms. So stricter diet, and started different protocols to try to either shrink the tumor or try to keep it at bay until I could find therapy that I was comfortable with. And that's when I connected with the group Save Your Thyroid with Jennifer, just reading that like a sponge. And so then I found out about radio frequency ablation, read about it, studied about it, and started looking into it myself. So unfortunately, for my experience, I haven't found a lot of physicians who currently treat a nodule the size of mine, cancerous, which was right at 2 centimeters. It measured in, I think, the first time at 1.8. And so I was turned down by 2 different RFA surgeons, and finally heard of one who would go up to 2 centimeters. So my oncologist sent a referral, and that started the ball rolling very quickly. And being in Oklahoma, I don't know of any other doctors who treat any cancerous nodules. And I just heard of some starting to treat benign nodules. So I flew to another state, had my procedure the day that I arrived, and flew home the next day. So I had my procedure on September 30th. This just, a few weeks ago. My sister died the day before with cancer. And so when Debbie gave her story, that brought me to tears, because I mean, when we talk about this, it sounds just so easy, but for me, having my sister die the day before, it was just quite terrifying. So I was one out of 660 patients who lost my voice, and I'm a vocalist. So I was able to make really small, strange sounds by the end of that day, and held off singing for a month. I would say that I sing 24/7 for days saved me. I wasn't given a lot of surgery instruction or even explanation, and not much post either. In fact, I didn't know when they said probe that it was just a needle. I pictured it as almost as round as a pencil, but not quite. So I wouldn't even take my bandage off because I didn't know what was under there. So that stayed on for 2 days. And when I finally peeked under there, you could hardly see a little needle prick or whatever. So I'm recommending to people ice a lot. So at my 1 month checkup, my tumor was 54% smaller, and my thyroid levels at this point all are in the normal range. And for me, I realize that, it's not gone yet, but I am so thrilled with my results up to this point. And even though I did have some issues that I think that I would have liked to have been different with the surgeon that I used, I'm thrilled with the results at this point. So thank you again, Jennifer. I really appreciate all that you've done.
Great. Thank you very much for sharing that, Aya. So that's interesting. 2 centimeters, we would call that probably a smallish, maybe medium-ish thyroid cancer. You've had sounds like a reasonably good response, 50-something% over the course of a month or two. Now, Dr. Kuo, I know you've got a clinical trial open for thyroid cancers and RFA. Who's your sort of ideal cancer candidate when you're thinking about ablation?
So with cancer, we kind of think about the whole procedure a little bit differently. With benign nodules, the goal is really just volume reduction of the nodule. If you have 20% left behind, those cells are benign cells. They're not going to harm you. They're not going to spread anywhere. But if you leave behind cancer cells, they're cancer cells. They will continue to progress. Eventually, cancer will leave the primary organ and it can spread. And so if you're going to do a procedure for cancer, then your goal should really be to clear the cancer, right? And that's where size comes into play. Smaller tumors, yes, depending on where it is, because not all, even a small tumor located in the wrong place is not going to be a good candidate for ablation. But a smaller tumor, you're going to have a better chance at clearing that tumor. And not just actually that tumor, but probably a rim of normal thyroid cells with it, right? Because you want a good margin. So the larger the tumor gets, the smaller the likelihood is that you're going to be able to completely obliterate that tumor. A normal thyroid gland measures 2 by 2 by 4 centimeters in size, or a thyroid lobe. So if you have a 2 centimeter cancer, you're not going to have a lot of normal margin around that cancer. And that's where you can have thermal injury to adjacent structures if it's sitting next to the nerve or, the trachea, the esophagus. There's a lot of critical structures that are near these nodules in the thyroid gland. So for our study, we do up to 1.5 centimeters and less. Because that's a size where we can reasonably, if it's located in the right spot, we can reasonably clear that tumor and get a nice safety margin around that tumor. So there are some that are pushing it. That 1.5 is a pretty accepted definition for a micropapillary carcinoma. There are some that are pushing it up to 2 centimeters, and certainly in Asia, they've been doing cancers up to 2 centimeters in size, but they're also getting more complications. So it is safety versus complications, and certainly as we are in the early phases of RFA in the United States, we would definitely want to err on the side of safety. We do not want to hurt our patients.
Thank you, Dr. Cole. And I think you've sort of covered this next point about the differences in technique. So I'll move along to Dr. Reeves. You're probably the closest we've got on the panel to a diagnostic radiologist, although I know you're interventional. Thinking about these small cancers that get ablated, what can patients expect in the first few months afterwards with regards to how their tumors are going to look on ultrasound? Do they shrink immediately? Is there any swelling involved? What have you seen so far?
Yeah, so good question. There's the whole patient experience, which is what they're going to experience, and patient selection, but then there's the imaging side of it. And for thyroid RFA, the objective evidence that we use is imaging. The subjective evidence is the patient's experience, and that is more important than anything else, how they're responding to it and how they feel it worked. But when it comes to cancers, that's a different story. It doesn't matter really too much how the patient feels it worked. It matters what we're seeing on imaging, and is the patient going to have a recurrence of cancer? So Jen hit this on the head. This is a different type of patient. Your margin for error is completely different than a benign nodule. So the goal is complete obliteration. So thyroid RFA works by heating the tissues to an incredibly hot temperature. The body will then kind of destroy the cells, or the heat will destroy the cells, and the body kind of shrinks down the nodule. That works great when a patient is experiencing cosmetic or functional problems due to an enlarged nodule. But the key with RFA with cancer is that temperature probe has to hit all the cancer cells to make it effective to cure the cancer. So right now, the best way we have of following this is with imaging. That can be done several ways. I think a lot of patients are experienced with thyroid uptake scans, which is very important for modulating, is the cancer present, is it not? Do you have metastasis, meaning has the cancer leaked out from the thyroid gland and gone to other areas, lymph nodes? So those types of uptake scans are incredibly important for monitoring the recurrence of cancer. Ultrasound is a bit of a muddied water for the first probably 3 to 6 months. After that, after things have kind of cooled down, then the changes in the nodule can be incredibly important. There's a system called TIRADS, which most patients have probably experienced because you can read it on your ultrasound report when you get done, but it's the way the radiologist grades the nodule based on how scary or not scary it looks. So a TIRADS 5 is the radiologist saying, yep, I think this is cancer. TIRADS 1 is the radiologist saying, this is definitely not cancer, or I'm almost certain this is not cancer. And that grading scale will come into play on all kinds of follow-up scans after the RFA is done in the setting of cancer. So right now, it's the best way we have of kind of gauging the objective evidence about whether or not a nodule is staying benign looking, or is it changing and evolving into something more sinister like cancer.
That's great. And I think you're sort of tangentially bringing up the fact that a radiologist who interprets these needs to be someone who's familiar with what tumors look like after ablation, right? So it's definitely a partnership between not just your surgeon or interventional radiologist or endocrinologist who's providing the RFA, but also needing to have that infrastructure of a radiologist who is comfortable interpreting these ablated glands. So Dr. Wren, Aya described some voice changes, losing her voice for a short period. I suppose we ought to interpret this as a temporary nerve injury. So, in your experience, particularly with larger nodules, what are some strategies that we can use to minimize this risk of nerve injury with RFA?
Yeah, so definitely an important topic. the most important means to avoid a nerve injury is to have respect for the anatomical course of this recurrent laryngeal nerve, which are these super important nerves that help give us a voice, and they do touch the thyroid for a short distance in the back. So the bad news is they are close, but the good news is they're essentially always in the same place, and it's very predictable. RFA proceduralists can avoid them by doing what we call the transisthmic approach, where we start from the middle of the neck and project the needle outwards towards the thyroid gland side being treated. So having excellent visualization of the entire course of the needle during the ablation time is very important. We have been instructed to assess for voice changes during the procedure, and I certainly do. And that if there's evidence of a thermal injury to the nerve, to potentially inject some dextrose or sugar water. And to be honest, I haven't had a situation where a patient had a voice change during the procedure, so I haven't used it. I would caution, based on my surgical experience of thermal injuries to the nerve, that it is not likely to come back so easily with, just some water. And so I think that prevention is really the most important remedy, and that if it does happen, it can take time to heal, and hopefully it will.
Great. Thank you very, very much for that, Dr. Wren. Now, I know we've got one more case on the docket, Katie, but I do see that we've ran over time. In fact, we've had such a good discussion so far. I don't want to rob our audience from the opportunity to ask their own questions. So let's shift for now to Q&A. We're running a little bit over, but we'll try to grab as many questions as we can. One question that has come up is for patients with a small cancer and cancer in a lymph node, is it possible to get both of those ablated at the same time, or does that sort of rule out that patient as a candidate for RFA? Dr. Kuo, I think you probably got more experience with this than anybody. What do you think?
So unfortunately, we do know that even teeny tiny subcentimeter thyroid cancers can spread to the lymph nodes early. And once it spreads to the lymph nodes, that is metastatic disease. RFA is a very targeted treatment, right? We're really only ablating a very precise nodule. When you have metastatic disease, that means thyroid cancer cells are floating around in the lymphatics, in your gland, maybe in the blood vessels. So that's no longer a very targeted, focused spot of cancer. The best way to achieve cure, if that is your goal, which I think for most cancer patients it would be, the only way to achieve that is surgical clearance. So if you have a small cancer in the thyroid gland, you have a small cancer in the lymph node, it's not just that lymph node that has cancer. In all likelihood, other lymph nodes in that region of the neck also have cancer cells. They're just not sonographically apparent. So your best chance for cure is to clear all that out. Now, after you have that clearance and you have a recurrent lymph node that comes back with some cancer cells, and that's the only lymph node that we can detect that has disease, that lymph node can then be RFA'd. But that's because you've cleared everything out and you have a very single focus of disease.
Another question that came up, can this also be done for BRAF positive cancers?
Depends on who you ask. So BRAF is a mutation, a point mutation that we find pretty commonly in papillary thyroid cancers, and it can be associated with more aggressive behavior. And so there's certainly physicians who believe that if you have a BRAF positive papillary thyroid cancer, because you're at higher risk for having an aggressive cancer, that is not a cancer that you should ablate. There are others of us who, if you have a BRAF positive cancer, that we don't necessarily default to a more aggressive treatment option. There are patients with BRAF cancers who opt for active surveillance. And so I don't necessarily rule out, or BRAF does not preclude me from doing an ablation for a patient, as long as all the rest of the tumor characteristics are amenable to RFA. Wonderful.
So it sounds like if you shop around, you may get different answers to that question from different providers of RFA. Here's a good one. What is the maximum size for a benign nodule for RFA? Another easy question that we are all going to agree on, a single number. I'm being sarcastic. Of course, we're going to have different opinions, but that's why we have an expert panel. So let's start with Dr. Wren. What's the largest nodule that you would be willing to treat with RFA?
So I don't think I have a set ceiling where I've said this is too big, or there's a cutoff, but I usually will, the bigger it is, I just change the expectations, and I counsel them that we do have some studies that suggest that larger nodules have a less percentage of volume reduction, and that, you know, for a nodule that is 8 centimeters or 100 mils in size, even if you get a 50% volume reduction, it could still look really big and still be causing symptoms. And we might consider it a good result, but you might not think that it's the result that you were hoping for. So I think that I always say that RFA doesn't close any doors. And if you're willing to try, I think that doing big nodules is usually very safe. But I do set expectations that a bigger nodule is likely to require multiple treatments to get a full treatment effect.
Excellent. I think we can pretty much all agree on that, you know, the larger the nodule, the lesser the treatment effect, the more likely it is that they'll need a second procedure. On this topic of a second procedure, if a person had, let's say, a suboptimal response from a first RFA, and they're considering a second RFA versus a surgery to take out that lobe, does a previous radiofrequency ablation make the subsequent surgery more difficult? Dr. Taylor, what do you think?
Well, I can say that at this point, I haven't had the experience of operating on any of my patients that have had RFA, so I can't speak from personal experience, but certainly the literature would suggest that there is no sort of increased risk of surgical intervention after RFA. And so, you know, undergoing RFA has not been shown to increase the risk of any sort of complication in association with surgery.
Great. I think I've read similar things as well. Here's a good one. One person asked, their nodule extends down just below the clavicle. Is that still a candidate for RFA if it gets, you know, into the what we call a substernal goiter sort of a scenario? Dr. Wren, Dr. Reeves, Dr. Kuo, any thoughts on that?
Well, I would say it doesn't preclude RFA. It just makes it a little bit more difficult for the operator to reach that portion of the nodule. So I've had patients like that, and I think it just kind of comes back to counseling at that point. The approachable nodule can be treated with RFA. The one that is going to be difficult to approach is one that you can't do, and you've got to be able to see it with ultrasound, and that's a very difficult area to see with ultrasound. So I think it would just be a matter of counseling the patient.
Yeah, you can't ablate what you can't see. Again, our priority should be safety. So that's an area that, you know, you're going to under ablate or not ablate at all. Now, I think the question was, it's not just a benign nodule, but a toxic one. So those cells that we can't see, we can't ablate, are also overproducing the thyroid hormone. So your chances of actually achieving normalization of your TSH with an RFA procedure would be much, much less the first time around. And you're probably looking for that additional session a few months down the road, once the top portion of the nodule has shrunk and, like, ideally brought up the inferior portion of that nodule.
Yeah, because the thyroid originates higher up in the neck, I think we all work under the assumption that if you do treat the portion that can be seen above the sternum, it will shrink the nodule. And so there will be areas that will not be treated, but will hopefully be brought up and will no longer be substernal as the rest of the thyroid shrinks. And so again, it's just about setting expectations, but it would not be a contraindication.
Wonderful. I think we've got time. One last question. An audience member asked, what are some other complications that can happen with RFA for benign nodules? We've talked about nerve injury. What are some other complications that could occur? Go ahead, Dr. Taylor.
Yeah, so other complications that can occur are you can have bleeding during the procedure or post-procedure that can lead to something called nodule rupture. And so that can be where an area that was treated of the nodule can swell, and you can ultimately get a rupture of that from the bleeding. That can create pain, swelling in the neck, sometimes can potentially even lead to need for some type of intervention. Most of those patients that experience that can be managed without any further intervention, thankfully, can be watched, and sometimes they require steroids. So the Medrol dose pack that was mentioned earlier can help with that as well. The other things that you can see is the potential for development of hypothyroidism or low thyroid. So by treating the nodule, you can potentially see folks develop low thyroid that may need to initiate medication, although thankfully that risk is very low as well. The potential for damaging other structures near the neck. So we've talked about the main nerve that we're really focused on, which is the recurrent laryngeal nerve. But there are another major group of nerves that called sympathetic nerves that can lead to something called Horner syndrome, where people can have sort of a droopy eye. They can lead to them having some increased sweating and things along that nature. And so those are some of the less common but other potential risks that can occur with RFA.
Great. All right. We have run well beyond the hour, so I want to thank everyone for sticking with us. I hope everyone's found this to be an informative and helpful session. I certainly have. As a reminder, if any of you have questions that we did not get a chance to address, we've got the panelists' contact information here on the screen. Please feel free to email any of us on the panel. I want to thank each of the panelists for lending us your time and your experience, and certainly Jennifer Holcomb for helping us put this whole thing together, and definitely the patient presenters who've been able to share with us your stories to sort of stimulate our conversation. And apologies to Katie for running beyond our allotted time. So, you know, I think the key takeaway, I think, is ultimately that RFA is going to grow, right? I think this is a technology that some people consider new, some people don't really even consider new anymore. And I think it's going to be more and more popular in the coming years. I believe I speak for the panelists altogether when I say we want to achieve and maintain excellent outcomes, right, as this technology grows. I think that's the right thing for patients, and frankly, that's probably the way that we can see continued increase in third-party payers as well to buy into this technology, and for medical societies to buy into this technology. I think you know, we all certainly share a passion for this technology, but you know, our number one priority ultimately when you come and consult with one of us is going to be recommending a treatment that's going to be effective and that's going to be making sense for the individual patients. So, you know, I think that's the important thing to remember. We want to save the thyroid. We also want to make sure that our treatment that we recommend is going to be effective for you. All right, so with that, I will close the session and wish everyone in attendance today a happy and restful holiday season. Okay, take care.
Thank you.
Thanks, everyone.
Happy holidays. Take care.